I'm an accounts manager here at Erchonia EMEA. Thank you for joining us today. We're excited to have Dr. Reis with us, who will be diving deep into the use of non-thermal high-energy laser therapy for migraine treatment. Tonight, Dr. Reis will walk us through clinical protocols, treatment strategies, and integrative approaches to care, showing how high-energy laser therapy is being used in modern migraine management. For those who haven't yet met Dr. Reis, he is a doctor of chiropractic medicine and a board-certified chiropractic neurologist at the Neural Connection. Dr. Reis earned his doctorate in chiropractic from Northwestern Health Sciences University, graduating magna cum laude, and completed his Bachelor of Science in Kinesiology, Exercise Science at the University of Minnesota, focusing on human motor performance in both athletic and therapeutic settings. Before we begin, please know that this webinar is being recorded and will be sent to all the registrants afterwards. You will also find Q&A box on the right-hand side of your screen. Feel free to type your question to Dr. Eric at any point during this session. We will address them during the Q&A portion at the end. So without further ado, over to you, Dr. Eric.
Okay, thanks, Jasmina. It's good to see you again, and good to see everybody else on the event. It's been a bit since I've been able to speak for you guys, so I'm excited to be here. And this is a new topic that I haven't really spoken a lot about, but it's something clinically that I have a ton of experience in, and I've been really spending a lot of time on migraine, cluster headaches, and this whole complex of this condition because it's something that is near and dear to my heart, having family members who've struggled with migraine. But more importantly as well too, I've had a lot of patients that I've seen clinically who have been to the massive hospital systems in the US. They've been to the Mayos, they've been to the Cleveland Clinics, they've been to the Cedars-Sinais, and they're still asking the question of like, why am I still dealing with these debilitating conditions and migraines? And so I'm excited for this topic because I think it's important. I think it's so relevant for anybody who's seeing these types of cases. And I'm realizing that a lot of people actually don't fully understand migraine and its clinical pathology. So I'm just going to do one quick thing on my screen here and get this out of the way. And we should be ready to go. So for those who have treated migraine, for those who have experienced a migraine, this picture kind of depicts like all of the emotions that come with that. Anybody who's had a migraine or has treated a patient with migraine, they will tell you that it's not fun at all. And this can be something that lasts minutes, hours, days. I've had some patients that will literally go into and out of a migraine over weeks. I have patients who have migraines for 15, 20, 25 days out of the month, and they run out of their sumatriptan medication within the first 5 or 10 days. And so I think this picture was a really strong depiction of what a migraine is. It's really this massive storm of structural, neurological, inflammatory, metabolic, hormonal, and even stress responses that are really wrapped up into one clinical condition. To just kind of lump migraine together with other headache disorders is really doing it a disservice. So migraines are a debilitating and quite disabling disorder that affects 18% of women globally and 6% of men worldwide. If you want to equate that, that's 1 in 5 females who struggle with migraine or migraine variants in some way, shape, or form. That's a lot of people. And so if there are going to be 8 billion people on the planet, that's a very large cohort of individuals who are struggling with this debilitating neurological and neurovascular condition. We used to think that migraine was just due to altercations in like vascularity, so the contraction, relaxation of different blood vessels, arteries, veins, things like that. And while that's not necessarily wrong, what we actually know today is that migraine is a neurovascular condition. So there's neurological properties, there's vascular properties, and there's actually inflammatory-based properties. And what's quite interesting about this actually as well too is that there's been some research and data talking about how migraine actually is quite more similar to seizures and epilepsy than it is to like classic tension headaches. So for those patients coming in saying, oh, I've got a really bad headache, I've got a migraine, you need to be really careful getting caught in that game, because there are so many differences between tension headaches and migraines, and whether they're post-traumatic, whether they're genetic, whether they're hormonal, there's a really significant component to this that needs to be considered from the clinical side if you're treating these conditions. So just a really quick overview of what actually happens with migraine. We know that there's altered blood flow and changes. We know that there are changes in brain wavelengths as well too. There's an asynchronous pattern that occurs that we can talk about throughout the rest of this. There's too much glutamate and not enough GABA. So too much of a gas pedal, not too much of a brake pedal. There's some interesting dynamics there with some physiology that we'll talk about, especially in the cerebellum, which is this part of the brain that is involved with fine motor movements, balance, and coordination. We know that there's different conditions or different situations like cortical spreading depression that we're going to get really nitpicky into and discuss why that's a relevant case. But there's a release of something called CGRP, so calcitonin gene-related peptide. This is something that a lot of pharmaceutical companies are chasing right now. They're creating drugs to mimic the kind of lock and key mechanism with CGRP, and we'll kind of touch on that a little bit more. But we know that there are genetics involved. There's previous history of trauma, whether it's physical, mental, perceived, or all of the above. All of that is relevant. Metabolic dysfunction is a really big factor that not many people are linking together. And then, of course, hormonal imbalances. So when we're talking about a migraine, we are talking about a neurovascular condition, okay? So there are genetics involved. If a close family member has migraines, your chances of developing them increases significantly. So some of the data is showing if you have one parent with migraine, you have about a 50% increased risk of getting migraine. Two parents, it's closer to 75% risk. So what I'm going to tell you is that the genetics can load the gun, but the environment, for lack of a better term, is always the part that will pull the trigger. And I've seen parents, I've seen kids, I've seen patients. There's some interesting twin studies that are actually coming out of Minnesota talking about how our genetics really are just this genetic blueprint. Our environment, our diet, our lifestyle, our habits are really what trigger those genetics to be turned on or turned off. That methylation process, that epigenetic layer that sits on top of your genetics, is a really important factor and facet to understand why maybe your sibling has migraines but you don't, or why you don't and your sibling does, right? So we know that there's about 40 genetic variants that are associated with migraine. It kind of involved three specific patterns. One is ion channels. So kind of going back to like basic biochemistry, that sodium potassium pump that is always using up and chewing up ATP to try and regulate your, your ion concentrations in the cell and outside the cell. That's something that is unfortunately affected with migraine, and that kind of sets people up for these migraine outcomes. We know that these pain pathways become sensitized. That CGRP molecule that I just mentioned is something that's really important for that. When CGRP gets released into the synaptic cleft or around peripheral nerves, it can trigger these nerves to send pain signals back, which kind of starts that metabolic cascade and then the neurological cascade as well. And then we know that hormonal regulation and vascular tone are two important factors. For a lot of the females out there who are getting migraine, once again, 18% of the global population struggles with migraine. We know that there are a lot of hormonal factors with that. And at the end of the day, when we're talking about migraine, what we're really talking about is how migraine affects and impacts the brain, right? So here we have this sagittal slice that I honestly use for every single lecture that I give, because I think it's such a beautiful depiction of the brain and the brain's capability. I think what's also important to recognize as well too is that the brain looks like this, but it actually functions like this. The brain functions with a vast array of networks and connections and relationships. And we see this in the concussion space, we see this in the traumatic brain injury space, we see it in the ADHD and neurodevelopmental situations. Just because one area of the brain is or isn't working, it doesn't mean that that's the only area that you have to treat. I'm going to make a really strong argument for the migraine cases that I've seen in the migraine complex, the pathophysiology of migraine, to understand that it's not just treating one area of the brain, it's really treating these networks and these interconnected areas of the brain because they're so impactful and they affect each other. So I love using this photo because this is a deep tensor imaging. This is kind of tractography. This is a really high level research-based functional MRI that is only used in research. That's way too expensive to use clinically. And that's why most of the time when you run MRIs and CTs of people's brains, whether they've had migraines, concussions, TBIs, you're probably not going to find anything unless you have an overt brain tumor, a brain bleed, you've got some sort of space occupying lesion. And in those situations, that's clearly going to be found, right? But you don't see the functional components of the brain and what's working, what isn't. And it's kind of the same analogy that I give patients. It's like, when you go buy a new car or automobile, you look at the photos on the internet, you go and you go to the parking lot and you go and look at the car and see physically if it's viable. That's what MRIs and CTs are really good at doing. What you need to do, though, is you need to go test drive the car. You need to see how it functions. What's the steering like? How sensitive is the braking and the gas pedal? That's more the functional testing and more of the functional areas that you're looking at when you look at inputs and outputs with the brain. And that's a really important concept to understand, especially when you're looking at the pathophysiology of migraine. Because once again, this is very different than any other condition out there. And as I mentioned, genetically, physiologically, and even from an inflammatory response, this shares more similarities with seizures and epilepsy than it does with chronic tension headaches. So just kind of let that sit in for a second, right? So the patient that comes in telling you that they got a really bad headache, you can't assume that that's a migraine. And if it is, there's probably things clinically that you need to treat that is going to be a little bit different than you treating the tension headache that they have. So the kind of state or the phases of migraine kind of start in this premonitory symptoms and in this premonitory phase. This is like the first 72 hours before the actual migraine sets in. Patients report seeing changes in their mood, their energy, their sleep patterns, their affects, even like food changes, cravings, hunger pangs, like these things can kind of come out. And it's highly linked to the hypothalamus. So this is an area that, as most of you know on this call, is linked to hormonal imbalances or hormonal regulation. So if we're already seeing some of this in this premonitory phase, then there's probably a high chance that hormones, stress responses, catecholamine surges from the adrenals are going to play a role in the inputs, outputs, and the impact on migraine. This is where many of these migraineurs describe things like, oh, I didn't sleep very well, lights are maybe getting a little bit brighter. This actually, for the most part, presents like these premonitory symptoms of an attack. It's not actually causes or triggers of the migraine. Now, there are true triggers, right? Like we know like dark chocolates, red wines, histamines, like different components metabolically can be triggers for migraine. But just because you see a bright light that usually isn't bothering you, that's not necessarily a trigger. A lot of times it's these prodrome or premonitory symptoms that occur. And about 1 in 3 patients who struggle with migraine, they can get something called an aura. And this is usually a change in their visual field. Some call it a scintillating scotoma, where you're seeing like patterns change visually. You can see parallel patterns, you can see overlap, or you can actually just get changes where you're just losing vision in general, which is quite scary for a lot of the patients that have experienced that. It's even scarier as a doctor when a patient comes in to tell you, hey, my vision is changing, after either you've done a treatment with them or you are treating them, because the first sign of that would inherently be, oh gosh, this patient is having a stroke, right? So it's important to rule in and rule out which red flags are actually occurring with these conditions. What's interesting about this aura phase, and I don't know if you can see my cursor or not, I can't see it, but I know Jasmina said that she could. I want you to pay attention to the back third of the brain, okay? Now, so cortical spreading depression is a transient wave of neurological depolarization in the cortex. What the latest hypotheses are talking about and discussing are this CSD process happening starting in the occipital lobe and moving all the way forward to the front part of the brain. So if you go from the occipital lobe, you move forward to the parietal lobe, then you move forward to the frontal lobe. The frontal lobe is like the first front half of the brain. And so what's interesting with this, and the analogy that I usually will give, is that cortical spreading depression is kind of like a wildfire burning out in the forest, right? So the wildfire kind of starts in one area and it just slowly starts taking over the shrubs, brushes, trees, whatever is in its way, right? That CSD process is kind of the same thing going on in the cerebral cortex of the brain. And a lot of times when people experience auras, that's going on in the occipital lobe, which makes sense, right? There's no peripheral nerve issue. There's no peripheral like problem with the eyeball. That process is neurological in nature. And so it's kind of like that wildfire burning. And as it goes throughout the occipital lobe, of course, you're going to get visual changes. But inherently, too, there are multiple forms of migraine variants. There's hemiplegic migraines, there's vestibular migraines, there's ocular migraines. And so in my opinion, what's going on from a hypothetical standpoint, that CSD process is actually continuously going through that area of the brain. And let's say that area gets to a part where vestibular integration is being processed. If that area is weaker than all the other ones, it's going to quote unquote burn up quicker with that fire going on, and patients might experience more vestibular based symptoms. The same thing could be said about a hemiplegic migraine. If there's one area of the brain or the cortex, or of the motor cortex specifically, patients are a little bit more prone to experience that hemiplegic migraine with the facial drooping, the loss of facial tone, things like that that occur with hemiplegic migraine. And so this is a really important phase because all of these happen before the actual headache phase. And I say that in quotations because of everything that I've just mentioned. Migraine is not just a bad headache. Migraine is a completely different neurovascular process and condition than related to everything else you're going to see with migraines. Now, this process and this phase can last anywhere from like 4 to 72 hours. Some patients it's shorter, some patients it's longer. I've had patients have it longer than that, unfortunately. TBD as to whether or not it's a proper formal migraine or if it's like these delayed effects that people commonly get. But this is where you see the nausea, the light sensitivity, the sound sensitivity. A distinguishing factor for a migraine specifically is that the migraine is unilateral in nature, okay, often covering an eye, part of the forehead, or the face, and it's a moderate to severe pain intensity. So this is not a walk in the park. Most people will be down for the count, and if you've seen migraines long enough, you kind of know the pattern, the trajectory. What hasn't really been respected or discussed is this post-drome phase, which is kind of the migraine hangover that a lot of people get. Fatigue, nausea, cognitive processing delays, neck pain, stiffness, all these things are kind of lumped together as with the migraine. And while it's not necessarily wrong, I think that there's not necessarily the respect that we've been given to that phase because there are things you can do clinically and medically to treat those symptoms. Most people just assume this is like the downfall or like the outcome of like taking migraine medications, the triptans, the CGRP antagonists, ibuprofens, the Tylenols, but it's actually its own part of a migraine complex. And it's really important to understand because when you take a look at migraine specifically, and if you take a look at the picture that I've been showing you for the last couple of slides, there's a specific pattern of the pathophysiology with migraine, right? So we talked about in the early stages, you get these changes in the hypothalamus, which is that little blue shaded area in the center of the brain on the right. And then all of a sudden you get this like aura phase, which is that cortical spreading depression, which is like that wildfire that starts in the back and moves all the way to the front of the brain. You can see there's different networks in the occipital lobe, and especially in the parietal lobe, and even starting in the motor strip, that are impacted with this complex and with this kind of set in of migraine specific outcomes. But when we take a look at it, there's a lot of things going on in the brainstem as well too. And I think the brainstem is kind of this enigma that we kind of know about, but we don't really fully understand or talk about a lot. So I use this analogy with patients, and I think it helps with a lot of the providers and clinicians that I speak with as well. Your brain is kind of built like a house. And the first thing that we would do if we built a new house is we would go and we would build a really stable foundation. And in that foundation, we would put things down there that we don't want to think about, but we need. And that's like HVAC, plumbing, heating, sewage, electricity, all these things that allow the function of the house to be able to work properly. And on top of that, we start stacking our layers on top of it. So we get the first story, we get the second story, and then all of a sudden we get the third story. The analogy that I use is that, the brainstem is kind of like the basement of the house. As you start stacking on these other layers, the pons, the midbrain, the cerebellum, the thalamus, and then all of a sudden the cortex is kind of what we attribute to being like human. We attribute the cortex as this area where there's cognition and critical thinking and processing of information. And that's relatively true overall. And that cortex area is kind of like the third story VIP suite of that house. But if your basement started like flooding, or if there's a fire in your basement, you wouldn't just hang out upstairs in that third story and hope somebody put it out. You would now allocate resources and bandwidth towards those lower areas of the brain to go and address the problem. And that's essentially what happens with a migraine, is that you're having these structural, neurological, metabolic, hormonal, and inflammatory based problems that start occurring in this lower part of the brain and brainstem. And all of a sudden, all these other areas start getting taken offline to the point now where the entire house, metaphorically speaking, is on fire. And so we have to understand that there are so many facets that go into treating migraine because of this. And it should come as no surprise that individuals who struggle with migraine, unfortunately, have maladaptive stress responses. So genetically, they can be loaded up and have issues. Hormonally, maybe they're tilted more in being estrogen dominant, or they're having pregnenolone steal because they're producing so much cortisol. There can be stressors, triggers, right? So smoking, alcohol, dark chocolates, red wines, tannins, even just like different food sensitivities can be a factor with this as well too. We know that sleep is a really big factor, and we'll talk about that. If you're not sleeping well, that can set you up to be more prone for migraine. If you have more migraines, you're probably not going to sleep as well, and so it's this horrible self-propagating positive feedback loop. We know that there are environmental stressors, okay? So it could be environmental toxins, it could be stress, it could be work, it could be life, it could be your spouse, it could be all of these things that add up. And then of course you have the neurological outcomes. So you have changes in your pain perceptions, with things that maybe weren't painful before now are painful. You get that cortical spreading depression that we just mentioned. Autonomics, okay, these automatic processes that happen in the background, which are primarily brainstem mechanisms, start becoming altered and faltered. And that's why everyone is talking about vagal nerve stimulation for treating migraine and migraine-related disorders. The list kind of goes on. And this is why it's really important, is that at the end of the day, yes, there are genetics, yes, there are structural, neurological, and metabolic issues, but it's relatively well established now that there's mitochondrial dysfunction underlying migraine conditions, and that we know this is a primary driver of migraine function. So you got changes in ATP production because of impaired oxidative phosphorylation, okay? Excessive reactive oxygen species, you get oxidative stress, which starts changing mitochondrial DNA, calcium dysregulation, nitric oxide imbalances. So nitric oxide is the most potent vasodilator out there, and there's a reason that so many people enjoy nitric oxide or taking nitric oxide. It's one of the benefits of people when they start using medications, start helping them, get erections. Like that's a nitric oxide enhancer. And as wild as those early studies were for going after cardiovascular outcomes, they realized that that was actually better for sexual function than it was for anything else they were studying. That's a really big factor, and that imbalance plays a pivotal role in the lack of vascularity and vasodilation of blood vessels during a migraine attack. We also know that impaired mitophagy and autophagy, which is just really hopefully controlled cell death, is impaired. So now you accumulate different broken pieces of mitochondria. Metaphorically speaking, your brain can't take out the trash. And so now you have all of this stuff adding up, which causes even more inflammation, ROS production, and impaired changes. And then of course there's the genetic links. So we know people with mitochondrial dysfunction have mitochondrial DNA SNPs. They can have problems with that. Sirtuin pathways, which are really looked at for longevity and biohacking. David Sinclair, his work out of Harvard, is really heavily focused on that. And whether or not he's right or wrong, we know that those pathways do exist. So as you can see, like mitochondria are a really pivotal factor for why these processes occur. They're also really important for understanding how to help us improve aging and lifespan. And how do we age appropriately or age well into our later years in our 60s, 70s, and 80s? Well, we're looking at this as really the panacea of all types of aging and the ground zero foundational elements for aging, and if we can actually do it, halting, if not reversing, aging. And some of the work coming out of David Sinclair's lab is discussing that maybe we need to reclassify what aging actually is. Is aging a disease? Well, if we classify aging as a disease, not this inevitable process that occurs, diseases can be treated, if not reversed, correct? And so there's this whole concept now that we're exploring, and a lot of the research is in mice, some are translating to humans, but a lot of it is looking at what can we actually do to promote longevity. And in every single study, it comes back to the mitochondria. They're looking at the mitochondria as ground zero, the fundamental factor for this. They're so important. They do so much more than what we've been led to believe. And this is just an area that is hot with all the research, all the funding, and all the modalities coming out. So, research study after research study after study after study just continues to talk about mitochondria and aging. And these are people that are way smarter than me. These are people that are far more published than I am, and they continue to come back to this. So this is a relevant piece, not only to mitochondrial function and linking that with migraine, but it's also important to connect this with mitochondrial function and low-level, high-energy, non-thermal laser treatment. So why us? Like, why do we actually age? I think this is a relevant question. And we all just kind of assume that this is a process that just happens, right? And so while that's true, What I would argue, and we all know these individuals, is that there are people who kind of defy aging. They don't look their age. Maybe they act their age, but they don't look their age. Or maybe they don't act their age. You know, I know people who are in their 50s and 60s who lift at 5 a.m. every single morning. I see them in the gym and I'm like, how are you able to do this? What are you doing? Well, I think being at the gym early at that point in time is actually part of their gig, right? So this inflammation pathology is really discussing the inflammatory or the chronic inflammation that occurs with aging. Now I'm talking about unhealthy aging, right? So inflammation inherently is important for us to have because if you cut your finger or if you have an injury, inflammation can be beneficial to trigger your immune response to go after a specific site or location to repair. But this chronic, relentless, unenduring inflammation is really what I'm talking about. And this is that chronic inflammation where when you run biomarkers or labs, you see these pro-inflammatory mediators show up time and time again. And that's C-reactive protein, interleukin-6, interleukin-1 beta, and fibrinogen. Now, those aren't the only ones, but what I want to tell you is that there's a strong relationship between these factors and like age-related chronic disease. And you see it time and time again in the research. What we know is that interleukin-6 is used as a predictive marker for aging. We know interleukin-1 beta is also an indicative factor of like chronic inflammation. And so if you can run these on patients, if you can run these panels or at least use them as markers or gauges for progress, you can actually show some pretty important changes with individuals. Now, some patients want to see that data. Some patients don't really care. Some patients are like, listen, yeah, I know I'm doing this. What do I need to do today in order to get better? And this whole discussion is completely relevant for patients who struggle with migraine because they are dealing with relentless inflammation as well. And this whole neurometabolic cascade of aging is actually quite similar to the neurometabolic cascade and the neuropathology of migraine. You have mitochondrial dysfunction, impaired molecular waste mechanisms, you have DNA damage, neural networks are being affected, stem cells inherently in the brain, guts, all throughout the body are going to be affected. You don't necessarily have glial activation with migraine, although you have gliosis on MRIs and CTs with a lot of patients who struggle with chronic migraine. So you can make a strong argument for that. But you have impaired stress responses, you have dysregulated calcium signaling, and then you have oxidative damage. So this is no different than most of the other metabolic cascades for aging. And why is this relevant to the discussion we're having today? Well, it's relevant because all of these things in some way, shape, or form converge onto mitochondrial function. And that's why it's so important, why it's so powerful that non-thermal high energy low level lasers are able to actually tackle and improve these mechanisms. Now, what is non-thermal high energy low level laser? We're talking about concentrated light, and I'm just going to use laser moving forward because non-thermal high energy low level is quite a mouthful, and I think most of you can take a look at the notes that I have listed here. Laser is concentrated light, and it's billions of photons of energy that are being thrown into the cell to optimize overall cellular function. We used to think that the only effect was due to the cytochrome C oxidase upregulation of this fourth complex of the electron transport chain. But what we also know now is that there's so much more to that story. Now, when I was in school, which to be fair, wasn't that long ago, about 13 years ago, I was taught that your mitochondria just produce ATP. And while that's true, they do so much more. They also can regulate and upregulate or downregulate inflammation. They have immune responses to them. We know that mitochondria have slightly different DNA than our human DNA. And so at some point in our previous history, hundreds, millions, if not billions of years ago, we formed a symbiotic relationship with mitochondria, just like we did with the bacteria that live inside of our intestinal tract. I mean, at this point in time, the latest estimates show us that for every one human cell that you occupy, you have about 5 or 10 bacterial cells that actually sit in your intestinal tract. So you're far less human than you actually were led to believe. And this is all important because your mitochondria are ground zero for not only for migraine attacks, aging and longevity, but for just improving cellular health in general. And I want to make a strong argument for why we should be using laser on every single one of our patients. It's for all of these reasons that I'm listing here. And you're going to see this show up time and time again because it's a great reminder. Not only is laser really impactful for just everyday patients that you're working with, but I'm going to make a really strong argument for every single one of these mechanisms for patients who are struggling with migraine. It's non-invasive, there's no downtime, there's no pain, We know that there are anti-inflammatory properties, altering the immune system. It can decrease stress responses. It's neuroprotective, pain relieving properties. I mean, the list goes on and on and on. And as I've talked about already with migraine complexities and pathologies, migraine is quite a complex condition. It's not as easy as saying, I'm going to give you a triptan and say good luck. There are patients who respond to that, but there's a high chance you don't see those patients. And so what we're really breaking down when we're talking about non-thermal low-level laser and we're discussing the mitochondria, we're talking about the specific complex in the mitochondria, okay? So it's the electron transport chain. Now, going back to your biochemistry days, this chain consists of 4 different complexes. So there's 1, 2, 3, 4. And there's different enzymes and processes that are responsible for this. Well, essentially what happens is the photons from laser can go into this electron transport chain. It can upregulate the enzymatic process of that. And the outcome is that these complexes produce more hydrogen ions through the recycling of NADH to NAD+ and FADH2 to FAD. Now, for those of you who are in the longevity space, who are the biohackers of the group, why is everybody taking NAD+? Why is everybody taking NAD infusions? Why are people doing NMN and NR? Because these are all precursors for mitochondrial function and this electron transport chain. The biggest problem with that is you can't guarantee that when you do an IV infusion of NAD+, that's actually going to get inside the mitochondria. You can't guarantee that when somebody takes a tablet or a supplement with NMN, NR, NAD, that they're actually going to absorb it. A lot of people have gut issues, especially patients with chronic migraine. And so the problem with that is that if you're trying to give these people supplements or medications or even IV injections, you can't guarantee that that's actually going into the cell. And this is where low-level laser is really effective, is that we know that when we shine light in that laser over a tissue, not only are you absorbing it immediately in that moment, but there are potential systemic effects that occur as well. And that's where things get really powerful. So your first question should be, okay, well, I know this electron transport chain is really important for the production of hydrogen ions, which then get turned into ATP, which is the cell's currency, the energy currency for the mitochondria. Well, then how do we know we're actually having an effect on this? Well, Erchonia has done that study. We know that different wavelengths impact different electron transport changes. And so there's a reason you're seeing multiple studies and multiple products coming out now, because we know that the violet wavelength impacts the first and second complex, that first and second electron transport chain. We know that the green wavelength impacts the third, and we know that the red impacts the fourth. Well, I have a question for you. How many of your patients are taking metformin in the office? I'm going to say about half of my patients are currently either on metformin or on some sort of medication to help them with their diabetes. Metformin, which is one of the most commonly prescribed medications, impairs the first electron transport chain. All right, so you're already taking out one of those electron transport chains with you taking metformin. How many of your patients are taking cholesterol medications? I'd say probably a lot of them. Okay, what we know is that patients taking cholesterol medications actually impairs the first complex as well. And so not only are you knocking out these complexes with different types of medications to manage metabolic issues, which to be fair, they should be, because that seems like a bigger issue, there's a common side effect of people taking these different statins. They talk about fatigue, they talk about muscle weakness, they talk about soreness. Well, they're impairing mitochondrial function to try and manage these different outcomes metabolically, but they're also having systemic effects on the mitochondria. And what's beautiful about this, once again, is that if you have these tools in your tool belt, you can upregulate those systems and those electron transport chains that are being affected by medications to potentially help alleviate those side effects and help them improve their cellular health. And that, to me, is quite a convincing argument. Now, we know that different complexes are affected in different ways. At the end of the day, the whole goal is to get you to be able to produce more ATP, because that ATP is then subsequently going to be used for repairing cell walls, repairing cellular damage, helping you to control inflammation. Every cell in your body uses ATP in some way, shape, or form. Those sodium-potassium pumps that I mentioned earlier today, those ion channels, are an essential factor and a really important factor for brain health, and especially in those who struggle with migraine. And there's a reason why using things like electrolytes for supplementation can be helpful for those patients, is because those leaky ions are chewed up and used up so much faster than in the general population. What's beautiful about this, though, is that most of the patients, when they're coming into your office, if they're having an active migraine attack or they're in that premonitory kind of phase, there's not much that you can really do with them. Are they ready for a chiropractic adjustment? Probably not. Are they ready for soft tissue therapies? Most likely not. Are they ready for injections? Are they ready for Botox? Are they ready for all these invasive tools or therapies? Probably not. So what's beautiful about that is when you use these tools like laser, you can promote neural stability, you can improve mitochondrial function. And what's beautiful about that is it's non-invasive and you don't have to touch the patient in order to have them get the benefits. So the question I always get is, where should I be applying these lasers and these tools? Well, I have it listed at the bottom. So one of the first areas that I go after is the neck, because I want to affect the vagus nerve. And I always use a 10 hertz frequency. That's at least what the data has shown me. I know that there are other providers out there who will tell you different ranges, and that's fine. The fact that you have the wavelengths of the lasers through Erchonia is the biggest factor you have going for you. The hertz and the frequency is just a little bit more fine tuning, but I always use 10 hertz because that's what the data in the literature shows. And so I'm always doing laser over the neck of my patients who struggle with migraine. After that, I'm actually going into the ear because there's an auricular branch of the vagus nerve. And you see this with some of the devices and tools coming out now, where you're using tragal or non-invasive vagal nerve stimulation through the auricular branch of the ear. The anterior 1/3 of the tympanic membrane is innervated by the vagus nerve. And so you can use that as a pathway to get into the brainstem to calm these different areas of the brain down. So the first area I go is the neck, right? Always 10 hertz frequency. Then I go the ear, and I go one side versus the other. If they're having pain on the left side of the eye or the head, I'm usually going to go the same side because there's an ipsilateral correlation there with the neural wiring. And then after that, I'll actually go after the olfactory nerves. Well, I'm talking about going into the nose. Now, this is an off-label use of the lasers, right? Erchonia doesn't have any FDA clearances for this, but that's why they have providers and doctors like me who are trying to find ways to use new applications for these protocols and tools. And so I actually put the laser right up to the edge of my patient's noses because I want to go inside the olfactory nerve, which has direct connections into the thalamus and inherently the hypothalamus of the brain. But I want to dampen as much inflammation as I can right into the brain. And there's a reason we do medications intranasally. There's a lot of quick responses we can get from that pathway as well. And so I'll actually put the lasers inside patients' noses, specifically with my EVRL. After that, I'm going over the locations of the face where they're experiencing the pain. I'll go over the forehead. So you have the trigeminal first branch, second branch, and third branch. I'll go after all of those, maybe by going after the trigeminal nerve bundle over here by the mandible over the temple, or I'll go over the individual places on the face for treatment. Just depends on what I'm seeing. And then the last thing is I'll go over the abdomen, okay? So as you can see, there's a massive vagal nerve correlation there with migraine. And I'm going to show you the data and why that's so compelling, okay? So we know that a lot of people are in pain globally. Chronic pain affects at least 10% of the population worldwide. Like I said, 1 in 5 females will be affected by migraine, and about 6% of men worldwide too. What's beautiful about this is that Erchonia has a ton of FDA-approved clearances. It has 22 of them to be precise. They're working on more. There's a lot of data and research coming out now about where they want to go. And there's a recent pretty big movement there on the data and the studies that they're doing. But they already have clearances for neck pain, shoulder pain, back pain, postoperative surgery, plantar fasciitis. They have 6 FDA clearances for fat loss and non-invasive body contouring. What's beautiful about that is not only has the technology been validated and verified, but their sham, their placebo, is using light-emitting diodes, LEDs. And so while that is still a similar phototherapy, what we can tell you, and there's a reason why they're doing this, is that not all light therapies are created equally. And why this is relevant for patients with migraine is that there are studies out there showing that laser therapy and Botox treatments are both effective means for treating chronic migraine with no notable differences in overall outcomes. Now, this is a smaller study. I think they had like 30 or 40 patients enrolled in this study, but kind of interesting, okay? So if you take Botox, which is a really well-known modality that a lot of people use for migraine management, if you're taking that, or you're comparing it against low-level laser therapy, and both treatments were shown to reduce headache days, lower acute medication intake, and decrease pain intensity, Botox is a little bit more invasive than low-level laser therapy, is it not? Now, for me as a provider, I can't administer Botox. But can I use non-invasive low-level lasers as therapies and treatments in my office? Absolutely. And I do all the time with my migraine patients, and they respond so well because Botox is a local treatment intramuscularly, whereas laser therapy is treating them structurally, it's treating them neurologically, it's treating them metabolically, it's also treating things vascularly because of that nitric oxide boost that you get with low-level laser, helping that vasodilation process occur naturally. What's interesting with migraine, and we know this with a lot of the data and research coming out, even taking an extrapolation from the triggers of what happens with patients with migraine, is that there's a notable gut-brain and brain-gut connection. Okay, I always kind of tell people like healthy gut, healthy brain, healthy life, because it's really so important now, especially today, with understanding that the foods that you eat are feeding the microbiome inside your intestinal tract. That intestinal tract, then therefore, has all these sensory seeking cells that are inside the enteric villi that are always testing to see what's going on in that gut. And if we have good bacterial profiles in there, our immune cells are happy, right? 70% of our immune system is located in our gut. So is 80 to 90% of the serotonin producing cells that we have in our gut. And anywhere from like 70 to 80% of the dopamine producing cells are also found in our gut, which is why so many people are looking at the current neurodegenerative models as metabolically mediated in the gut, neurologically based outcomes. So we're looking at Parkinson's, we're looking at Alzheimer's, we're looking at different movement disorders, we're looking at MS, as all of these things that are neurologically outcomed, or these are neurological outcomes that are metabolically mediated. So the foods you eat, the foods that you put in your body, the things you put on your body all manifest this way. And we know that the gut has a massive connection with the brain, and the brain has a massive connection with the gut because of this amazing nerve complex called the vagus nerve. Now, this is your 10th cranial nerve. And what's really interesting about this, specifically from a migraine standpoint, is if you take a look embryologically about the growing of these cranial nerves, all right? And these are just large peripheral nerves that come out of the brainstem. Cranial nerve 10, cranial nerve 9, cranial nerve 7, and cranial nerve 5. Okay, so cranial nerve 5 is the trigeminal nerve. Cranial nerve 7 is the facial nerve. Cranial nerve 9 is the glossopharyngeal, right? And cranial nerve 10 is the vagal nerve. All 4 of these nerve complexes kind of came out from the same branchial area in the embryologic development of your brain and body, which means that when you stimulate one of those branches or one of those areas, all of the other areas inherently get correlations and stimulation based off of that. And this is one of the leading factors for why vagal nerve stimulation can help with migraine. When we think of migraine, we think of this trigeminal nerve complex in the face, this first, second, and third branch of the trigeminal nerve. What's cool about that is you don't have to go stimulate these hot areas for somebody who's having an active migraine attack. You can stimulate its distal cousin, the vagus nerve, which can inherently have effects centrally, metabolically, neurologically. Now, we know that the vagus nerve consists of primarily, it's probably about 4-to-1 ratio of sensory to motor nerves, okay? So you're essentially getting all this information from your guts, your chest, your heart, your lungs, your liver, and sending that information into the brain. It's kind of this environmental survey that's always giving your brain feedback. And we know that there are several anti-inflammatory mechanisms that have been touted and responsible for these anti-inflammatory effects that are occurring with vagal nerve stimulation. And I'm going to talk specifically about those, but these are the current conditions that are being used and investigated with treating the vagus nerve via non-invasive vagal nerve treatments. So we're looking at rheumatoid arthritis, which is a autoimmune condition, okay? Bookmark that. Depression, anxiety, PTSD, gastroparesis, migraines, cluster headaches, concussions, TBIs, and seizures. I've seen some studies that are helping people lose weight. I've seen some studies that are helping people manage different neurological conditions. The list kind of goes on because of these far-reaching impacts and outcomes from the vagus nerve, which I think is so cool. And I've been on this kick for about 3 or 4 years now about what is actually going on with vagal nerve stimulation and what are ways that you can stimulate that naturally. So there's 3 really well-known anti-inflammatory pathways that are implicated with vagal nerve stimulation. The first one is this HPA axis, so this hypothalamic pituitary adrenal axis. This is the release of cortisol from the adrenal gland. Now, we usually say, well, cortisol equals bad. And for the most part, maybe, okay? Acute release of cortisol is anti-inflammatory. There's a reason you get a cortisone injection into a joint is that can actually dampen inflammation and it can halt pain responses. But you can only get so many cortisone shots into a tissue. Well, why is that? Well, cortisol or cortisone can break down tissue, structural tissue, but it can also too have a chronic inflammatory outcome like this, especially when you have this chronic, relentless, unenduring release of cortisol. The second pathway is this cholinergic anti-inflammatory pathway, which is essentially the release of acetylcholine under these alpha-7 nicotinic acetylcholine receptors of macrophages. These macrophages are immune cells, they dampen inflammation, they halt immune response, and that's the mechanism. The third system is this splenic sympathetic anti-inflammatory pathway, which is relatively similar. It just binds onto splenic lymphocytes. And so we have these well-known anti-inflammatory mechanisms at play. So then why the vagus nerve and why migraine? Well, we already talked about this. When you stimulate the vagus nerve, these nerves project into the brainstem, release different neurotransmitters, and you can modulate migraine pathways. What I think is super interesting is that when you stimulate the vagus nerve, you can actually inhibit the cortical spreading depression that occurs. So remember, that's that aura phase, that's that prodromal or premonitory phase of the migraine. We know that you can also stimulate the trigeminal nerve by stimulating the vagus nerve. So when that trigeminal nerve gets excited, you can increase the production of GABA and serotonin. You can decrease the production of the excitatory neurotransmitters glutamate. That's a really exciting mechanism. And so these are really important factors because it all deals with neuromodulation, it deals with inflammation, and it deals with the immune function or dysfunction that can occur with all of these pathways. So it makes a strong argument about why we would want to continue to do that. And I'm going to bring you back to this concept. Your brain is really built like a house, right? If you have a rocky or leaky foundation, then you're probably not going to get much functionality from that house. And you have to go where the problem is. And this is really important because of these anti-inflammatory properties of the vagus nerve. They have anti-inflammatory properties after being treated, but you can actually use vagal nerve stimulation to prevent different inflammatory pathways from occurring. And this is where things get really interesting for me, is that when they've done studies on transcutaneous vagal nerve stimulation, they've actually seen changes in autonomic function, cognitive processing, mood, and even sleep. We know that people will improve their autonomic outcomes and autonomic responses with the use of vagal nerve stimulation, which just inherently makes sense based off of what the vagus nerve does and how it regulates your autonomics. We also know too that it can help you balance your HRV pathways. So that tandem balance between your sympathetics and parasympathetics is a really important molecular pathway, but neurological pathway as well too, because this is an important indicator for quality of life and your ability to go from a stress state to a not so stressed state. And so traditionally speaking, if you wanted to get a vagal nerve stimulator, this is what it would look like. It'd be an invasive procedure right over the carotid sheath, most of the time over the left side of the neck. And this was traditionally used for people who were dealing with medication-resistant epilepsy and seizures. Well, I don't know about you, but I'm not signing up for that anytime soon because there's far easier ways to stimulate the vagus nerve. And one of those ways is actually by using Erchonia's EVRL laser. This is a study that they did with Clixton Machado, really interesting study where they essentially used that laser over the left side of the neck for 10 minutes, right over the carotid artery, right in this little junction right here on the neck, because that's where the vagus nerve wraps around the carotid artery, and that's an easy access point to get there. What they found is that in these outcomes, non-thermal low-level laser was really effective at modifying brain function. It could be useful for depression, neuro rehab, dementia, autism, of course with migraine headaches, concussion, brain injuries. And this is what the outcomes looked like. So they did quantifiable EEG analyses before and after using the vagal nerve stimulator. And these are some of the outcomes that they found, which is quite convincing and quite enticing to take a look at. We know that these lasers influence the autonomic nervous system. If they didn't, you wouldn't get the outcomes that you just saw. And so this red and blue, this red and violet light together can actually stimulate and upregulate the parasympathetic nervous system and autonomic responses, which to me, clinically, is really interesting and really convincing. So the question should be, well, how do you stimulate the vagus nerve? Well, you can do it in a multitude of ways. It's not just vagal nerve stimulation via low-level laser therapy. You can do it with belly breathing, which I give to every single patient who comes in an autonomic mess. You can also do it with humming and singing. You can use it with digestion, smells, everyone's doing cold plunges and using saunas. You're changing the functionality between your autonomics when you're doing that. I'm also a massive fan of using gamma core. So we have the consumer version, which is the True Vega, which is an unlimited amount of use, but I use it with patients all the time while I'm doing low-level laser with them, because this is an FDA cleared, FDA approved modality for cluster headaches and migraines. It's available throughout the EU and the US as well too. And it's as simple as literally holding this over your vagus nerve, doing a protocol for 4 minutes, and then letting it go. And it's a really effective modality, especially when it's paired together with low-level laser therapy. Because we're not just talking about the neurological and the metabolic outcomes, there's also a massive, heavy emotional burden for a lot of individuals who struggle with migraine. There's a landmark study that was published where people with depression were 3.4 times more likely to develop migraine. And in the reverse, people with migraine were 5.8 times more likely to develop depression. Sad. It's a self-propagating cycle. But here's what's interesting about that is if you treat one of those conditions, they actually show that there's beneficial and secondary outcomes with the other, which kind of makes sense, right? So if you're in less pain from migraines, you're probably not going to be as depressed. And if you're not as depressed, you're probably not going to be as prone to migraine attacks because your brain's probably functioning at a higher level. But what we know and how this ties together with migraine is that a lot of individuals who struggle with mental health issues have higher levels of pro-inflammatory cytokines. It's the same markers that we were talking about earlier: interleukin-6, tumor necrosis factor alpha, and interleukin-1 beta. And so the question we have to ask is, if inflammation is this silent killer, well, where does inflammation actually start? Outside of overt trauma and damage to the head, what I'm going to tell you is that inflammation commonly starts in the gut. And we talked about the gut-brain connection in migraine and chronic headache. Well, we know that this is something that's been well established in literature thus far too. Once again, another thing that's impacted by vagal nerve stimulation. And so if you're depressed, you're most likely inflamed. If you're inflamed, you're most likely depressed, unfortunately, as well too. It's a massive two-way street. That's a self-propagating cycle. One of the things that we're finding out more and more about with migraine attacks is that food choices heavily matter. And it's not just the glutens and the dairies and the food sensitivities. It's actually the blood sugar fluctuations, the hypoglycemias, the hyperglycemias, the pre-diabetic, before you chronically have diabetes diagnoses, where a lot of people are struggling with this. A lot of these patients are coming into your office where they get hangry, where they get emotionally unstable because they haven't eaten food for quite some time. These fluctuations in blood sugar can trigger inflammation. That inflammation can trigger unstable neurons to be triggered. Those unstable neurons either fire or they don't, or they blow up, and all of a sudden you have this neurometabolic inflammatory cascade that sets you up for these migraine attacks in the first place. Metabolic dysfunction, which alters mitochondrial function, is an underlying pinning factor for treating debilitating migraine headaches and being able to actually understand how to actually get somebody to be in a better state. Because by the time most patients find me, and I don't know if this is you, they've tried the triptans, they've tried the medications, they've tried the SSRIs and the SNRIs, and they're looking to me to challenge the thinking as to how they're going to overcome their chronic migraine attacks. Well, these studies continue to show time and time again that these insulin spikes, or these spikes in blood sugar followed by insulin, can be really impactful for the development of chronic migraine and these inflammatory responses that I've just discussed. So why is this important and why is this tied together with using laser therapy? Is because every single one of the mechanisms that I just covered can be treated with low-level laser therapy. Every single one of them can be utilized and deployed by you or by an assistant in your office, where you know they're actually going to be absorbing the photons. You're not dependent on them swallowing pills or supplements and hoping that it gets to the mitochondria in time. You're using a pathway that's really strong and really impactful and beneficial for the cell because it focuses on mitochondrial function and DNA replication in those spaces. And so I want to remind you that regardless of the type of provider that you are, whether you're an MD, you're a PT, a physio, a DC, or any other provider in between, you're a receptor-based provider. Whether you're giving a medication, a supplement, an adjustment, a soft tissue modality, or even doing talk therapy, you are changing the brain and the physiology of your patients. And that comes with a massive responsibility, but a massive opportunity to help a lot of people, especially when you understand the implications and complexities of what's actually going on when you're treating migraine cases. So for those of you who are like, listen, wow, maybe that was a lot. Here's the screenshot that you want to take, and here's what you want to take to the bank, okay? These are the most evidence-based migraine treatments that I can find that I use clinically with my patients who come from all over the US to come to our office in Minnesota, okay? Of course, first and foremost, I love using non-invasive treatments and therapies. So I'm using non-invasive low-level laser therapy to treat all my patients for all the reasons that I just listed. I also use non-invasive vagal nerve stimulation and belly breathing because those are just really nice complementary modalities to also use. But I'm metabolically mapping out all my patients' pathways. I run blood chemistry panels, labs, but the bigger thing is I focus on habit change and behavioral changes because that's a really big factor for getting people to actually change. Physical exercise has a bit of an asterisk to it. Too much of a good thing can be a bad thing, and exercise is definitely one of those categories for people who struggle with migraine. Even just taking a 15-20 minute walk if you're not in shape could be enough to trigger an inflammatory response for a migraine. And that's why you have to meet those patients where they're at. But in the right dose, physical activity can be very therapeutic. We also know that supporting people on sleep, supporting people on stress responses, and things like that can also be very therapeutic for these patients as well. And then, of course, we have our nutrition and supplementation. So there's a great study that I referenced here, the role of nutrients in the pathogenesis of treatment of migraine headaches. That's where I got some of these. Vitamin D3, K2, and magnesium, really well established, really well known. 400 milligrams of niacin to be vitamin B3 is one of the most effective preventatives to be prophylactic for migraine. But just take all of the B vitamins and make sure they're methylated if you're going to do it, because they all play a role in mitochondrial function, neurological function, and the recycling of homocysteine and methylation pathways, which are important. And then you have coenzyme Q10, ALA, electrolytes, and everything with gut support. And everything, once again, converges on mitochondrial function, mitochondrial integrity, and taking care of your mitochondria to take care of you. So I come back to the same slide that we started with. Why would you choose to use non-thermal, high-energy, low-level laser? It's for all of the factors that I listed below. And this is one of the most effective tools in my tool belt to help me treat the chronic migraine patients that are coming into my practice, who've seen all the other docs, they've tried all the other things, and they're asking, Dr. Reis, what can you do to help me? This is my go-to tool for those patients. So with that said, any questions, any feedback? Jasmina was going to help me list some of these out. So if there are people who have questions, I'm happy to field those and take those right now at this time. If there aren't any, or you want to ask me a question personally, you can shoot me an email at the email listed below. And I'm happy to take any questions or field any responses from that.
Well, I have one question here from one of our attendees. They're asking how many minutes would you use on the areas such as ears and forehead, I believe, with the lasers?
Yeah, it depends. I will commonly go 2 to 5. It just depends. Like if I have somebody who's got a ton of pain over the face, then I'm gonna probably maybe go a little bit longer over that area. Of course, they're wearing goggles, right, to make sure nothing happens with the eyes. But I'll usually do 2 minutes, 2 minutes, 2 minutes, and get a 10-minute dose throughout the body and over the areas that I usually go. But it kind of depends clinically what you're experiencing and seeing as well.
Great, thank you. And I've got another question which says, does Eric only use the vagus settings, I believe, with the migraines?
I do for the most part, yeah. And the reason why is because that's what the data shows, right? So with all the vagal nerve therapies coming out, with all of the things you're going to see vagal nerve stimulation on the neck, you'll see vagal nerve stimulation over the mastoids, you'll see vagal nerve stimulation as headphones. There's a bunch of different devices out there. And so they're all looking to treat migraine headaches or migraines in general. And so for me, the research is thick enough and the quality of the studies are good enough for me to say, yeah, let's just use a 10 hertz frequency for all of these data points. Because if my job neurologically, metabolically, structurally, and from an immune pathway standpoint is to upregulate vagal function, then I'm going to try and do everything I can to do that. So I will have these patients most of the time on a 10 hertz frequency, regardless of the type of laser that I'm using.
Okay, says, thank you, Eric. Most studies are small sample, and as with many interventions, the parameters, the protocols are varied. What would you use in terms of treatment approach, power, wavelengths, etc.?
So I only use Erchonia lasers. So when you look at the milliwatts, the power, the wavelength, right? So I use violet, I use red, and I use green. So those are the three wavelengths that upregulate the electron transport chain complexes. I use Erchonia's lasers, not because I speak for them, but because they're FDA cleared and they're approved, right? So I like showing that there's double-blind, placebo-controlled, level 1 multivariable studies that are done on products before I use them on my patients. And so that's important for me. And so I'm using Erchonia's products and I'm using those lasers in my practice combined together with the protocols that I just mentioned. So that's why I have conviction for it, and those are the things that I use for my patients as well.
Great. There's another one. It says, excellent information. Thank you. How frequent would you see your client, especially cluster headaches?
Cluster headaches? I don't treat as many cluster headaches as I do migraine, and those are different conditions, although they are similar, right? So cluster headaches commonly affect men more than women, unfortunately, and they're with that ice pick stabbing pain in the back of the eye. They can come with seasonal changes, so they are a bit of a different condition than migraine. Is the question specifically about cluster headaches, or is it about migraine?
It's just the cluster headaches. Yeah.
Okay, so I can't really speak too much on seeing those. I have seen about 15 cases in my career over the last 13 years of cluster headaches, but what I would say to you on that is it just depends, right? So with cluster headaches, similar to migraine, what I'm going to tell you is that there are structural, there are neurological, there are immune, there are metabolic pathways that are inherently affected. So if I'm seeing them for an active care, if I'm seeing them for like when they're having their painful headache, I may see them for a couple times in the week, right? And if it's back to back to back, sometimes I'll see them on a daily basis till they're out of that. But once I'm in a management phase where I'm saying, hey, let's look at labs, let's look at blood chemistry, let's look at hormones, things like that, I may not see them very often. They may be on a management where they're doing dietary changes, they may be using supplements, they may be doing home exercises. My goal is to get my patients to be self-sustaining and autonomous so that, in the most loving way possible, they never have to see me again and I can kick them out of my office. So it just depends on what phase of care or treatment that they're going to be in for that. But once again, that's a clinical judgment that you're going to have to make with every case. Every patient that I've ever seen with that condition, every single one of them has had to been treated slightly different because of that. So that's an important factor to consider.
Okay, any experience with vagal nerve stimulation and fibromyalgia?
I don't see a ton of fibro, so I can't really comment on that, but I know that there's data pointing to that. So, it's something that's convincing. And what is fibromyalgia? It's a different situation for every person, right? It's kind of a sham diagnosis given to a lot of people saying, hey, we don't really fully know why you're in pain, but you're in a lot of pain and you have, the diagnostic criteria is you have to have pain points and sensitivities in so many X amount of places. What's causing it, right? Well, inherently, there's probably going to be some sort of sensorineural wind up or some sort of sympathetic wind up, kind of like what we see with like chronic regional pain syndrome, where you have the sympathetics winding up and neuroplasticity working against you. And so in that situation, I would make a strong argument, why would you not want to use vagal nerve stimulation? Whether it's laser, whether it's a vagal nerve stimulator, whether it's a auricular vagal nerve stimulator, could you do something centrally to the brain? Could you neurologically do something to alter that firing and wiring of those pain pathways to potentially help that patient? I think it's worth a shot. Now, I'm not doing, vagal nerve surgery. I'm doing non-invasive vagal nerve approaches. So with a lot of those patients, they really struggle because they don't really have a single treatment or a modality that they can use. I think vagal nerve stimulation has a promising future in that condition.
Okay, there is one quite interesting one. It says intermittent fasting is reported to improve dysglycemia and also increase mitochondrial autophagy. Comments or any discuss on this?
I would say to a point, right? So I'm a massive fan of intermittent fasting. I do it 5 days a week during the week, but when I started off doing it, I was not good, right? So I tried to have caffeine one morning when I was starting fasting and I almost blacked out before I saw patients. I would get really tired. I'd get dizzy. I'd get lethargic. You just have to meet that patient with where they're at. So I agree with you. Intermittent fasting has some really good research and data validating with autophagy, mitophagy, balancing out insulin sensitivity, glucose levels, but you have to be very careful. You can't just put somebody on a 5-day fasting protocol like what I'm doing. You have to meet them with where they're at. So once again, metabolically, you have to be careful with that, because if you put somebody into a fasted state who's hangry or who does have dysglycemia, and all of a sudden they have these random glucose spikes, or they have a significant drop in glucose, you will trigger a migraine attack. And the research is quite rife with that. So you just have to be careful with saying, hey, we're gonna put you on this protocol. What's probably gonna be better is getting them to eat like 2 or 3 or 4 meals a day with high fiber, quality fat and protein, and a little carbohydrate, get them into a level state where their blood fasting glucose levels are more level, and then start slowly introducing fasting throughout the day or throughout the week, right? So you just got to be careful with some of those things, because one of the things you have to consider with fasting is you are also chewing up a lot of cortisol. So what's keeping your blood sugar level when you're fasting? Cortisol release from the adrenal glands. Well, extended cortisol release or cortisol insensitivity can also be something that could be another trigger for a migraine attack. And so you just have to be careful. It's always taken into consideration with what the patient can handle. And that's coming from somebody who's a massive advocate of fasting. I've just made enough clinical mistakes to give you the caution on that. So just don't do the same thing that I did, and you're probably going to be better off because of it.
And the last question is, do you treat unilaterally with single-sized migraine?
Can you ask that question again? I'm sorry.
Do you treat unilaterally?
Okay.
I guess I pronounced that quite well.
You got it. You got
it. With single-sized migraine.
So I think the question is, so if there's a left-sided migraine, would I treat like the left side with like the vagus nerve and stuff like that? And I would say, yeah, for the most part. When you look at like the pathology, like the neurophysiology of like how those cranial nerves come in, a lot of them are ipsilateral, and that's not all of them, but like when you're talking about the vagus nerve, it is. So if I'm going to treat that complex, I'm going to do the same thing. Even if I'm treating like the face, the trigeminal nerve is ipsilateral. So I know it's, the left trigeminal nerve goes into like the left pons. So if I'm treating all of that in general, I'm going to be treating the same side. Inherently, I would do that. So left-sided migraine, treat the left auricular branch, treat the left side of the neck, treat the left trigeminal system. You can go after the full gut if you want to, but I would do everything unilaterally. If you're not getting the outcomes or results you're looking for, you can always try the opposite side. Your brain inherently, that you cross talk in as many areas as possible. There's so much overlay and correlations with that, and so my brain, when I'm doing stuff on the right side, has to know what's going on that side and compare it to the left. So I always go unilateral first, and if not, I'll try bilateral as well. So it's just kind of clinically what you're finding.
Perfect. That's all for tonight.
Great.
Thank you very much, Dr. Reis, for sharing your expertise and valuable insight with us today.
You're so welcome. Thank you for having me.
And big thank you to everyone who have attended this session. We really appreciate your time and engagement. Just a reminder to everyone that the recording will be sent to the registrants after we finish our session automatically by your email. And if you have any further questions, please do not hesitate to reach out to us. Well, have a nice evening, everyone, and thank you for tuning in. Bye-bye.